First of all, let me thank the organizing committee for inviting me to participate in this conference. This is the second time that I got invited. Thanks to Dr. Juwaria and Dr. Waleed and all the other organizing members. We did learn yesterday that there is a lot of different risk factors between men and women, and we need to accept that women are not small men. Yeah. And there is a lot of difference between men and women. This is the way that women go shopping compared to male. And this is the difference between men and women, that they really, they say they are ready within 5 minutes, the same way that the man said that he's come back home within 5 minutes. And also taking the picture, Armstrong took 5 pictures when he went to the moon, but she took 37 pictures when. And this is also the difference between men and women. Really, men insult each other, but they don't really mean it. And women compliment each other, but probably they don't really mean it. We mean it. No. Okay. Let's go now to the really risk factor of the women. Everybody thinks that the women has great risk from breast cancer, but just remember, cardiovascular disease is the main risk factor, and that's followed by chronic lung disease, and then lung cancer, and really, breast cancer comes really at the end. So, but this, I'm sorry to say, most of the women think that they'll die from breast cancer, and they neglect about their cardiovascular health. So the approach with that, I'm sorry to put this slide, that was the bikini approach to women health. That's from Dr. Nanette Winger. Again, she was mentioned by our keynote speaker yesterday. And we really concentrate on breast cancer, infertility, and obstetrics, and forget about the cardiovascular disease. So we need to change this approach to women health. Again, the inclusion of women in the clinical trial is so difficult. Look at that, just we can put men in the clinical trial easily. And again, the same slide that was given by our keynote speaker yesterday. There. Now, let's go back to the true differences between men and women for the pathogenesis. For the pathogenesis of acute coronary syndrome, there is difference. We know women erode. They erode the surface of the endothelium, and that may cause acute coronary syndrome or MINOCA, compared to the men that cause plaque disruption or explode. So that's the true difference between men and women. So let's concentrate on one of the topic, which is SCAD. SCAD stands for spontaneous coronary artery dissection. There is a lot of other abbreviation that stands for, I came as a medical abbreviation that's called segmental colitis associated diverticulosis, and that's for the GI people. But just remember that I'm going to say SCAD, but that stands for spontaneous coronary artery dissection. And how's that happening? We know that there is intact intima, and the people thought that probably there is some rupture in the intima, and that's caused the dissection. And but this is most likely doesn't happen with an intact artery. I think the right thing, although we do see that on the angiogram, look at that, there is the dissection and there is 2 lumen here. I put the arrow. But the problem is really that happen is intramural hematoma. It's not intimal dissection. And this is the intrahuman hematoma. That's the intramural hematoma that's caused compression of the lumen. And this is very unlikely to happen that we get tear in the intima. So with that, the compression of the lumen cause this appearance here that I put two arrows here, and they cause compression of the lumen, and very unlikely that we see intimal flap. And with that, we need to get intravascular imaging, especially OCT, to see this intramural hematoma that's around around the intima. So this is the pathogenesis. So let's concentrate. It's intramural hematoma that because of bleeding inside the intima. So this is the way that women explode. They explode inside the media or sub the intima, contrary to the men that they explode directly in the intima of the artery and cause thrombosis. Here, thrombosis is very unlikely. So with that, Jacqueline So from Vancouver came to classification of this SCAD. This is the type 1. Type 1 is the true dissection that you see two lumens and intima flap. But this, as I said from the beginning, is rare. The most common is type 2, and there is this type 2A. There is compression and between two normal segments. This is the proximal normal segment, and this is the distal normal segment. And between that, this is type 2A. And remember again that we don't see any intimal flap here. And type 2B, that's the compression extends till the end of the artery, to the end. Look so why is that? I'm sorry. Let's go back. Okay. This is type 2A. This is type 2B. Okay. Type 2B, there is compression of the lumen that extends to the end of the artery. Look at this PDA that extending the compression to the end of the artery. So that's type 2B. And type 3 is really difficult to differentiate between atherosclerosis and type 3, that you see this focal intramural hematoma that very focal and surrounded by normal artery, and that may mimic atherosclerosis. And with that, we need some intravascular imaging to diagnose that. So this is the classification. However, on the other side of the Atlantic, in Europe, they use another type called type 4. And type 4, that's when there is total occlusion distally. And I'm sorry, what's... Okay. Okay. So this is type 4. They said total occlusion distally. And with that total occlusion, if you concentrate here, proximal to the total occlusion, there is compression. So it looks the same like type 2B. So in the American way, we don't use this type 4. So it's only type 1, 2A, 2B, and 3. So with intravascular imaging, there are two types, the OCT and the IVOS. There's some limitation to each other, but we really hardly need to do that. Just we need to document the diagnosis by coronary angiogram. And those are the types 3, and this is the angiographic result. Let's review the study of the angiographic result. And if you see that, with the angiographic result, you see that around 60% is type 2. So that's the old thing, that we are missing all those 60%, saying that this could be atherosclerosis and narrowing. And because of that, they thought that this SCAD is really a rare disease. But it's not a rare disease. And only we see type 1 in around 29 to 30%. So this is to keep in mind. So once we keep that in our mind and we put the history, and maybe you may use intravascular imaging, we may get the right diagnosis. But unfortunately, only about 8% get intravascular imaging for the diagnosis. And again, SCAD affect mainly the left side and the LAD, more the other. However, there is around 8% that affect the left main, and that may cause cardiogenic shock or acute coronary syndrome or hemodynamic instability. So how do we treat that? If it's the patient is really developing small MI and she is hemodynamically stable, that's better to treat her conservatively. And this is the idea. Just keep the patient in the hospital. with conservative management and watch her for more than the normal MI. So if we watch the MI for 3 days, we need to watch here the patient for 5 to 7 days in order to avoid any recurrence of SCAD or extension of this dissection that may compress another vessel and or affect jeopardizing the myocardium. So this is the, however, if the patient is high risk presentation like presenting with cardiogenic shock or the left main, as I said, then we need to intervene. Now, what's the medical therapy? The medical therapy mainly is aspirin and beta blocker. And there is no data and randomized data. However, the retrospective study showed that giving beta blocker improved survival and prevent recurrence of SCAD. So this is the point. We are waiting for a randomized study. There is prospective randomized study, 2x2, studying the effect of beta blocker and aspirin. But adding the other medication like clopidogrel or S inhibitor, if there is LV dysfunction, statin, it doesn't work unless the patient has history of atherosclerosis or calcium channel blocker doesn't work. So in this SCAD study, this is from the Canadian study, you see in this study around 86% treated conservatively. And those patients, only 2.5% required intervention, whether bypass surgery or PCI. And the other received the other treatment. But just again, it's around 84% that treated conservatively, just without any intervention. And with that, only 14% required PCI. And what's the reason why we need to watch this patient? Because if you follow the patient, do angiogram after 3 or 5 or 6 months, 95% will heal spontaneously. So there is no point to put the patient, jeopardize that patient and give her extra stent or do unnecessary intervention. Again, the intervention may carry the risk either of iatrogenic catheter dissection or extension of that intimal flap or extension of intramural hematoma and cause damage to the artery. So this may happen. However, again, if the patient presents with cardiogenic shock or diffuse disease or multivessel disease, that may need intervention. So what's the PCI outcome if we intervene? We said that we usually intervene around 14 to 15%. But what's the result of that? Look at that. The success of the PCI is around 30%. That's the success. And there is partial success in 40%. So we are not really successful because of those things that we talked about. So there is this table how to intervene. But anyway, it just the patient is hemodynamically unstable. We need to intervene and try to complete the sealing. So this is a type 1. You see the intimal flap here. So we need to cover the whole flap. So with that, we put long stent, and with that, we got good results. So this is okay. However, there is another type 2A. You see here just the compression of the lumen. We stented proximally, distally, and then we got nice result. But that's required 3 stents. So this is a full metal jacket and put the patient at a risk for developing restenosis. Again, this is let's go for a type 2. This is a patient. Oh, sorry. Okay. So you see here the diagonal is involved. There is dissection. And with that, there is no point to put stent in this small vessel. So the idea of using cutting balloon that dissect the intima and cause more flow. So we use the cutting balloon and we got good flow to this diagonal. So keep the cutting balloon is a strong indication for treating that. Look at this patient. This is hemodynamically unstable and got cardiac arrest. Look at the poor LV function. You see the ostial total occlusion here at the LAD. So we tried this cutting balloon and nothing did work. We did cutting balloon multiple times here, and you see the angiogram after that. This is the cutting, just of the cutting balloon, no change. So we decided to put a stent, and in order to put a stent, that's ostium, we need to put the stent to the left main. So we put the stent extending to the left main, and this is the nice result just for the left main. Here we are. Okay, this is the stent, and we got good result just for the left main, but look at the LAD, we don't have good flow. So we use here the cutting balloon in the distal, and we got nice result just for the distal LAD. So we avoid putting too much long stent. So for the CABG, we really reserve the CABG for the patient who has left main dissection and he's stable to go to the OR, and we don't know which graft to use, whether Lima or SVG, there is no difference. And the idea is just to put flow. All those grafts will close later because of the healing and the competitive flow. That's what causes closure of the graft. So CABG is rare and happen in about just 0.7% of the patient. Now, what's the outcome after 3 years? This is again from the Canadian study, and the outcome, look, the death is rare, less than 1%. But the total MACE is 14%. And what are the total MACE? Is around 10% MI. And this recurrent MI, while the reason for the recurrent MI is extension of SCAD or iatrogenic SCAD. So de novo recurrence is rare, is only 2.4%. And that's to bring the idea. The idea, whoever a patient gets a SCAD, don't get pregnant again, you may get recurrence, but this is the data. The recurrence is less than 2.5%. And all of this MACE happened early in the first 14 days. But after that, there is no increase in the MACE. So it is acceptable to let the patient get pregnant, at least from my point of view. I know we need more data. And what's the reason we are getting good 3 years outcome? Because of all the patients receiving aspirin and beta blocker in this study. However, another point to mention that the recurrence of chest pain, whether atypical or typical, is quite frequent, around 40 to 50%. So the patient may get recurrence chest pain and get present to the ER again with chest pain, but this is not recurrence of SCAD. And the reason for that, there is, we'll discuss that, but there is some predictor of this MACE. The genetic disorder, for example, if the patient has Marfan, Lewis-Dietz, or Ehlers-Danlos, the peripartum dissection is a high risk to develop MACE. And the last thing is the FMD, or fibromuscular dysplasia, that's associated, that's increased the risk of recurrence of SCAD. So when we are treating SCAD, the acute hospital management, there is long-term medical treatment, rehab, and screening for predisposing arteriopathy, and especially FMD that I mentioned about. What other predisposing factor? Everybody is, in women, stress, emotional stress, and FMD. But in men, it's either FMD or carrying strong thing. So it's easy to diagnose that in men. And just SCAD happen only in 10% of men. So there are some strategies to prevent SCAD. This is like giving beta blocker, management of hypertension, reduce emotional stress, reduce physical stress, avoid hormonal therapy, avoid treatment for migraine, and triptan is another thing to avoid. Now for the peripartum SCAD, remember, it's a really high-risk SCAD, this. There is increased incidence of MACE, and that's happened mainly in the major artery, or either in the proximal LAD or in the left main. And there is high in hospital MACE. However, as I mentioned, chest pain after SCAD is quite common, but is not due to recurrence. And there is a lot of things to consider, like impaired coronary flow and microvascular dysfunction. And there is in this study that they did a microvascular study, and there is increased incidence of that. So just if the patient continues to recurrence of chest pain, we need to do microvascular function study. Now, is there genetic predisposition? There is no true gene for SCAD. However, there is some gene association, and there's the data from Mayo Clinic that there is one allele that's the factor 1. If the woman has this allele, she will get increased predisposition to FMD and SCAD, and that's happened in 90% of the women. However, the other allele that happened in around 75 in men, and on the contrary, doesn't increase the SCAD, but increase the predisposition to atherosclerosis. So we'll wait for future study to tell us whether what gene predisposition will get. Again, there is no specific gene for SCAD, but we'll wait for further study. So just to remember, SCAD is not a rare disease, but we need to keep that in mind and think about the differential diagnosis and do the true study even in the coronary angiogram or intravascular imaging. Remember, conservative therapy is the main study, and the main treatment is conservative unless the patient is not stable, and the long-term 3 years outcome is really good. There is strong association with FMD, and consider strategies to reduce SCAD. So I'm done. If I have a time, I want to tell you my story about my first SCAD and how I did get really interested in this. Yeah, you do have this is a lady, she's 31 female, presented to the ER 10 days after giving normal delivery to her third child. And she presented with nausea and vomiting and epigastric pain. So her vitals in the ER were normal, and she was giving antiemetic and antispasmodic prescription and was sent home. Even the ER doctor did not bother to check any ECG or troponin or anything. Her symptoms resolved within less than 24 hours. However, 3 days later, she presented to the ER with aphasia and right-sided weakness. So there were no complaint of chest pain at that time. So her head CT showed no intracranial bleeding, but there were focal infarction. So at that time, they checked the ECG, and the ECG showed recent anterior MI with Q wave in all the precordial lead with some ST elevation. She was given aspirin, clopidogrel, low molecular weight heparin, and thank God that her right side weakness improved significantly, and the hospital course was unremarkable. No congestive heart failure. She was discharged 4 days later on aspirin, clopidogrel, atorvastatin, carvedilol, and they avoided ACE inhibitor because she was breastfeeding. Coronary angiogram was recommended, but she was in a rural area. So she presented to my office with this explanation. I repeated the ECG, no change. I did the echo, there is anterior wall hypokinesia, and I recommended angiogram. As you see, her ejection fraction was 35%. So this is the angiogram, and you see here the normal angiogram. This is the LAD, and looks okay. This is in the iliocranial and the epicranial. But here on the second, as I said, we did see something at the top of the left vein. You see a little flap. Did you see that? I'm sure you see that. I put an arrow. Okay. So, and this is what I call left main shot. That's the iliocaudal, and we do see the flap here. I'll just concentrate on this flap here. But anyway, the patient was stable, no complaint of chest pain. So I kept the catheter and wanted to look more closely on this angiogram. So I was discussing that with the team, but the patient just within a few seconds, although the catheter still in place, nobody moved it. She did complain of chest pain. And so we did the angiogram. Okay, now you need to give me some. Okay. Either we continue the case or that's...
Reem, can we get the images? No, there's nobody here. We just need his presentation again. No, okay.
So this is when she started to complain of chest pain. Look at the changes. We do see now like almost total occlusion of this ramus intermedius, and this slow flow happening in the LAD, and there is now staining at the left main, just within few seconds. Okay, so now blood pressure dropped, we started dopamine, we did extra views, and we thought that this is SCAD. So again, this is further the angiogram you see now. Now this dissection, and you see staining now in this ramus, you see that. So it's clear. And so why did that happen? We asked Isaac Newton, and he said that's dissection, friction, and intramural hematoma. So what to do next? I asked Tom Cruise, and he said, mission impossible. Even Ethan cannot help you. Okay, Spider-Man did not, even really Superman offered just to escape and asked to get me out of the cath lab. Only Alfred Hitchcock accepted to do this horror movie with me. So I did triple wiring to all those three, and did just ballooning to this flap in the LAD. And with that, we got significant improvement. And look at that, just after ballooning, we got significant improvement in the flow in all those three arteries, circumflex, the ramus. Look at the ramus, looks much better, and I don't see now any staining, but there is slow flow in this OM. I just put that arrow. So again, we did more ballooning, and we got significant improvement, but still, you see that this flap in the top part of the left main, and at the bottom, there is this flap. So now Superman came and he said, you can put a stent, and that's it. So we put stent in the ostial circumflex, just on the ostium, and we got significant improvement in the flow to the OM. So we thought that this is nice, and we give nitroglycerin, and we got significant improvement to the flow to the OM. So we thought now the LCA is fine. So again, so we stented the ostial LAD, and we got good result. And now the LAD is fine, the circumflex is fine, and even the ramus looks fine. And there is this still flap. And whether to do complex stenting, or that's if we stent the left main, we may get the hematoma again compressed. So we decided not to do anything, but just the idea whether we need to put stent in this ramus. So at that time, there were no pressure wire and no all of this to calculate FFR on that. So we used the mind of Einstein to help us. So we try to calculate the flow in all those arteries by simple thing. The velocity by calculating the frame count and the diameter and the length of the artery. From that, we calculated the blood flow. With that, we got normal flow in the ramus. So we decided not to do stenting in the ramus. This is the idea that how to calculate the length of the artery and then the flow. You don't need to learn that. But this is the final thing. We got TIMI3 flow and nothing impaired. So we decided to stop here. Just we did a post dilation of the stent and did simple balloon to the left main and the patient did well. So we are not done yet. This is the final angiogram. We took the wire out. This is here, and we need to complete the coronary angiogram. So this is her right coronary angiogram after 2 hours, and this is her LV gram. And just because of sort of SCAD, look at this aortogram, and with that you see this FMD. She had the FMD in this right renal artery. So anyway, this is just to explain what's FMD. You see the fibromuscular dysplasia, and you see this seat and beads in the arteries. We follow up. The patient, thank God, did not complain of chest pain. We did stress test about 8 months later, and she was fine. And she did not complain of extra chest pain. I tried to persuade her to do another angiogram just to see, but she refused because of a lot of things, fearing of that. So I offered the nice thing. I said, I'll pay for that coronary angiogram, and she agreed. So I paid that for that coronary angiogram from my pocket, and this is 16 months later, and you see now everything is healed. Even the dissection in the left main is healed. And here the angiogram. And this is the left main shot, and you don't see that. This is the right coronary, and this is the LV gram. So, and she got pregnant 1 year later, so this was Napoleon that I like the victory. And just this is the way that when you do interventional SCAD, it's like performing on the balance beam. So you need to be safe, effective, and work as Nadia Comaneci. Probably who doesn't know Nadia Comaneci, in 1976 in the Olympic Games in Montreal, she got 10 out of 10 6 times in this gymnastic. So, so that's the story, and I think that's enough. Yeah, thank you very much. So this is the first case that I have a SCAD and got me involved.